I'm going to be presenting some of the postdoctoral work that I did at Columbia Medical. I'm now a professor at Texas A&M Kingsville, but we've continued to follow up on my postdoctoral work. And this concerns behavioral and electroencephalographic, EEG, progress towards a biomarker for autism in early infancy. It's a long-term goal to be able to have a biomarker for autism. It would be so valuable, but this is sort of the very beginnings of getting towards that goal. So just a little bit of background. Why study autism? Some statistics. It affects 21.7 million people worldwide as of 2013. Also, as of 2013, 1 in 68 children is diagnosed on the autism spectrum. So now with the DSM-5, Asperger's syndrome and autism are all seen within one spectrum, that you can have severity of autism. And so 1 in 68 is somewhere on that spectrum. And this is an increase of 30% since 2012. So that's just 1 year. Suddenly there's an increase of 30%. Part of it may be due to this change in diagnostics. And also with the increase of interest in autism, parents may be more sensitive to noticing autistic traits in their children and thus refer their children for having autism. And so the underlying cause of what this increased diagnostic capacity is still debated. So why would I be interested in studying autism in early infancy? Well, how do we diagnose autism now? Usually it's behavioral and neurocognitive markers such as children not following your eye movements, not making good eye contact. Autistic children, they don't use gestures like pointing, or if somebody tries to point to show them something, they stare at the finger. They don't follow the point. So that's some of the first early signs. And then they end up not developing language in some more severe cases, so they don't reach those milestones. Usually they babble, and then the speech procession stops. So these are recognized when an autistic child in later infancy or childhood hits these milestones, but it would be so valuable to know that they were having problems earlier in infancy. So early detection for risk in autism, as well as other cerebellar-involved disorders, and I'll talk more about that at the end of my talk, would be immensely valuable because we could do early intervention, the type of interactions that are helpful for autistic individuals. And so the hope is to have some sort of, that this research will eventually turn into an early detection technique that's used widely. So for instance, it would be like what's done now with the auditory EEG response. Newborn infants across the United States, they use EEG to test infants' hearing. As newborns, they put an electrode over the temporal lobe and they play clicks very quickly, repeatedly, and they look for a certain EEG response. And the infant doesn't have to be awake. There certainly is no instructions to this newborn infant, but that's just their brain responses to the clicks. And so that is now widely used as a way to detect hearing deficits in newborns, and it would be a hope that maybe our behavioral or EEG work would someday eventually lead to a screening of not necessarily, yes, this child is going to have autism, but they're at a higher risk of autism or another cerebellar related disease. So what is the link between autism and the cerebellum? So one marker that's seen in autism with children once they're old enough to get into an MRI for a structural MRI, and also adults, is that their cerebellar structure is atypical. It's usually certain lobes of the cerebellum are smaller and they don't show the same cellular or not exactly cellular, but the structure of the neuronal layers is not as clear as it is in the typically developing cerebellum. And then when we've done some research with functional MRI, once the autistic individuals are older, and this is usually only possible with the higher functioning autistic individuals due to the requirements of absolute stillness in a magnetic resonance imaging machine, we're able to see that the blood flow there, the blood flow response that's measured by a functional MRI is not the same in this cerebellar area. So just a review for, I'm sure all of you know, some of the roles of the cerebellum. It's still being explored. Whoops. So it's still being explored. There was a really great book that came out called Being There, which was a whole book about how the cerebellum may play a role in just our consciousness and our order of thinking. So that comes out of some research, but of course we know the cerebellum is related in fine motor control and abilities, and it was known that it played a role in motor sequences, but as was talked about in that book, it also now seems like it plays a role in cognitive sequences. And if you think about how we plan ahead for our day, how I plan to walk to the front of the room, it's got sequences to it. Problems sequencing your cognition are very debilitating. And then also, we think of the frontal lobes and prefrontal lobes for higher level cognitive functions, but there's very interesting connections between the cerebellum and the frontal region, some neural tracks there that it seems like the cerebellum is feeding into these higher level cognitive functioning areas, even though you would wonder why would a fine motor area need to do that. That's why they think there may be some issues with the cerebellum being related to frontal functioning. So why would I measure eye blink conditioning? So that's the paradigm that I'm using. I wanted a measure of functioning of the cerebellum, and I wanted a measure of functioning in the cerebellum that I could use with young infants. So the paradigm I used that we know engages the cerebellar frontal network is eye blink conditioning. And how do we know that it engages the cerebellar frontal network? We know it from functional imaging. We know it from animal models where you cause a lesion in the cerebellum, you're not able to get eye blink conditioning. You have a lesion in the frontal areas, you're not able to get eye blink conditioning. But interesting enough, it's not hippocampus-based memory. You can have an animal with a lesion in the hippocampus, and they're still able to get eye blink conditioning. So how can we measure conditioned eye blink in newborns? And when I'm talking newborns, my participants were 24 to 48 hours old. So you have some limits on what you're able to do with them. So we wanted to see if we were conditioning the eye blink response, the eye blink reflex. But if you want to see if someone is blinking, it's very easy if they're awake and they're looking at you and their eyes are normal. But that cute baby fat, that chubby little face, well, there's a lot of subcutaneous fat in the face and actually around the eyes. And so seeing a blink is actually challenging with a newborn, especially if they're asleep, which newborns spend the majority of their time either eating or sleeping. So we used electrooculogram, which is an electrode near the eyes, to measure the eye rotation with blinks. So as you blink, it is not just a closing of the eye, but your eye actually rolls up and down. And because of the organization of the retina, this causes a large potential, much bigger than EEG potential, that allows us to see that the blink has occurred. So we're not measuring the motor constriction of the eye, because that would require us to put the electrode very close under the eye on the eyelid and that would not be tolerated by a sleeping newborn. But you can put the electrode on the cheek right below the eye and on the forehead and still get this measure of electroencephalogram of the eye rolling. And then we also are getting a direct measure of the cerebellar network functioning through electroencephalogram and specifically event-related potentials, which is the electroencephalogram patterns that happen time-locked to a current event, to a certain event. So event-related potential screenings with newborns is promising, as I said, based on how they're able to do event-related potential hearing test screenings now across the United States. So the first study really looks at, can newborn infants learn eye blink conditioning during sleep? Do newborns learn during sleep? That was unknown. It wasn't something that we already knew that they could do. And so study 1 and study 2 that I'm going to talk to you about look at electroencephalogram and event-related potentials to examine if there's evidence of successful eye blink conditioning in sleeping newborns, and if there is engagement of the cerebellar frontal circuitry. And this is during sleep because, as you probably know from being around infants, when they are awake and crying, they're moving all around, and you don't require the absolute stillness that you do with MRI to record electroencephalogram, but you do need some aspect of stillness. So it's best if they're asleep. And eye blink conditioning can be conditioned in adults when they're asleep, children when they're asleep. So we thought we may also be able to induce it in newborn infants when they're asleep. So in study 1 and study 2, here are the stimuli that were used. So I don't know if you can see very well, but you see little edges of some black speakers here. They had a foam pillow around their head, this very soft memory foam, and they had speakers that were next to their ears. We, of course, measured with a sound meter that the sounds were not damagingly loud. We also made them so they had a slow rise time, so they weren't quick onset, which causes a startle response just as a sound. And then we also had a tube here, and you can't really see, but there's a little tiny hole in the tube that is positioned so that it's diagonally going to just give a little air puff to the lower eyelid. So just enough to get a little blink. So obviously we checked with neonatal doctors, and they assured us that our pressure of air would not be damaging to the infant's eyes. So we recorded eye movement from an electrode that was the closest to the eyes. That was this one here, which is right between the eyes. And then as well as from these frontal leads here, which are close to the eyes. And then also, as you can see, this was high-density EEG recording. It was 128 electrodes that were on these newborn infants. So here's just a little bit of the setup. We would get the infants right after feeding, because that was when likely they would be able to sleep. We would put heart rate electrodes on them, so we also had a measure of their state and a breathing respiration band. So that's us putting the respiration and heart rate on. These are my research assistants from Barnard. We had a number of students come to Columbia Medical from Barnard to get experience. And here's the sleeping baby, almost a little bit of a smile there, with the electrode cap on, the electrode net. The electrode net is made with sponges, and we soak it in warm, sterile saline. So this makes a connection with the scalp and is complete. And we disinfect, of course, the cap between infants. But it allows us, to work the electrodes so that any hair they have, we make a decent connection with the scalp. And so you see the baby is swaddled. That also helps induce sleep. And then here we are recording heart rate in this computer over here, electroencephalogram over here. We're videotaping to see if we can actually see any evidence of the blinking. And then we also have here keeping the tube positioned on the infant's eyes. So that's how the procedure went. So how did our eyelid conditioning trial go? It was a very simple paradigm. I'm going to go into detail with the paradigm for study 1, but you'll understand the basics for study 2 and study 3. Just a 100 millisecond tone, a little bit of a slow rise time so we didn't get a startle to the tone. And here there's no air puff until 900 milliseconds where there's a quick 100 millisecond air puff. And of course we're looking to see, do they blink? So they should, because that's what we're trying to elicit. This air puff is meant to elicit a blink. So that's a conditioning trial, the kind of pairing that you're going to do over and over again. And then we had a reflex maintenance trial. So we just wanted to make sure this reflex is staying throughout our testing period. So we don't have any pre-tone. We just have on its own 100 millisecond puff to make sure that they are still blinking. They're still showing the reflex response. And then these were the trials that were most important to us, were the probe trials, where we would have the 1 second tone, but yet we wouldn't get the air puff, and that's the trial that really matters. Do they still blink when they hear the tone? Is it enough that they blink and that they blink at the right time? So right here, we expect to see an eye blink. So we were watching them visually squeezing their eye tighter, but as I said, it's very hard to see, but we wanted to try. And then electrooculagram, which is, as I said, a large size potential from the electrode close to the eyes. So this is an example of electrooculagram conditioned eye movement response in tone-alone trials. So here's where it's the onset of the tone. This is microvolts. And these are different leads that are further from the eye, so we didn't want to think it was a response that's happening across the whole head. We wanted to be sure it was just a response of the eye. E17 is that electrode that's right between the eyes, and we saw a large potential here. This is much larger than EEG potentials are, so we know it's not EEG. And so when we saw this pattern where there was not a potential in the electrodes that were far from the eye, but there was a large one, at the time that we expected the puff to happen, we would say, yes, there is a blink response there. So this is our data based on the electrooculagram. This is the proportion of conditioned responses. This is our control group. It was only a few babies in our control group, about 4, but that's pretty standard for this. It's just a proof that this condition increase is not happening on its own. And you see, it's surely not. This is to the tone-only trials. And then we saw increase, nice linear, almost, it was a little bit overwhelming how nice it looked, increase in responses to the tone alone, the probe trials. So we also looked at the event-related potentials, and so we looked at the late slow wave. And if you know anything about event-related potentials, you'd be like, what is the late slow wave? That's not something I've ever heard about in adults. Well, infant EEG is very different looking than EEG in adults because the scalp, the skull is not completely ossified, so it's a much larger amount of electricity comes from the scalp, from the brain through the scalp. And also Obviously the finer tuning of neural structures and neural functioning is not there, so you have a tendency to have big responses and not very intricate responses. And we just know from studies with older infants that when there is a positivity in the later part of the waveform that's shown to a sound, it's after a memory has been formed. So we just know this from studies with some older infants, and we're generalizing down to younger infants. So this is, the first half is the solid line, and the second half is the dotted line of our study, first half of the second half of the study. And we're looking at these frontal regions. Why are we not measuring from the cerebellum if we're so interested in the cerebellum? It's a deeper structure. And with EEG, you really are measuring mostly what's happening on the surface of the brain. And also, there's a lot of muscle that is covering up the cerebellum, and muscle gives off much larger electricity than does the brain. So it's just, you can't really measure directly with EEG from the cerebellum, but we know there's this cerebellar frontal circuitry that's underlying eye blink conditioning. So that's why we looked at these frontal sites, which are nice and easy to get. We don't even really have to worry about a whole bunch of hair. And so as we saw, as we expected to see later, this is the auditory response. You see it's 4 microvolts. You can compare that to the 60 microvolt eye rolling response. And then you see a more positivity in the late wave than in the second half than in the first half. So that gives us behavioral in terms of EOG as a measure of behavior, electrooculogram as a measure of behavior, as well as ERP, event-related potential evidence of cerebral-mediated learning in sleep newborns. And we saw specifically the slow wave potential late in the conditioning study. And again, we hoped that this could be standardized for newborns' study of dysfunction in neural circuitry. So let me tell you a little bit about goals of study 2. One of our major goals was to replicate study 1, since it was the first study that showed any newborn learning. And we were looking at the eye movement response, and we were looking at evidence of coordination of cortical circuitry, EEG coherence. And EEG coherence is when, this is a pretty simplistic vision of it, but these two regions are both firing in synchrony versus one region firing one way and one not being in synchrony. And so again, we're looking at the same paradigm, and we still saw conditioning, so we were glad to see that alone to the tone alone trials, and less so to the unpaired. This was data that was collected by the person who followed up on my research, and I was like, oh, my data was prettier. So, but it was still there. And then looking at the coherence, we looked at the first half and second half of the session, and at this period of time before the puff, and we thought that there would be a difference in coherence between learning, specifically that there would be increased coherence after learning. So after learning, these regions would be working together. Oh, little did we know. So first, let me show you how I'm going to look at coherence. It's going to be red lines that show coherence between some of these electrodes, and I'm comparing the coherence before and after conditioning. So in the first half of the session, there's a lot of coherence happening, and a lot from more frontal to more parietal regions. We were really interested in that. So, wow, it's going to be just tons of coherence. That's more coherence than we were expecting in the first half. So what's happening in the second half? Not having any coherence. So it ends up actually being, and this is largely exploratory research, so we replicated that newborns can acquire the eye movement response, but it seems that there's coherence early in the session when these regions are starting to coordinate together, but not later in the session. It seems to be during the acquisition phase. And so let me move on quickly to study 3. This is where we changed what the auditory tone was to be a woman's voice. And why would we change that to be a woman's voice instead of a tone? Well, autistic individuals process verbal stimuli, auditory verbal stimuli differently than non-autistic individuals. This study was done with 1-month-old infants, not with newborns. So you can think they have a pretty good amount of experience with the maternal voice by 1 month. And actually we know from other studies that prenatally they hear muffled versions of the mother's voice. So it was a social stimulus that we were using. And these are full-term infants. There was a voice group, a tone group, and a reversed voice group. We had that because it's the same complexity of stimulus. And so this was not done with EEG. This was done in another laboratory following up on ours. And this is the way they delivered the puff. They're not showing it right under the eye. And that's their measuring of electroencephalogram, but they didn't have the EEG measures. And so we have the tone or voice, and then the 100 millisecond puff. And so here's the data for that. Forward voice is here in the black line at the top. Pure tone is under that. Backwards voice is under that, but not sort of overlapping with it. And then unpaired voice and unpaired tone. So these are groups where they weren't paired, they were just presented randomly. So we are seeing some more final conditioning to a tonal voice. So let's just get to the end here because I'm running out of time. So some future directions for this. Obviously, we want to look at the EEG responses to social stimuli since we only have the behavioral electroencephalogram for that. And we would want to study special populations who are at increased risk for autism. Particularly, this is siblings of those who have autism. So we'd look at infant siblings of children who already have autism or somewhere on the spectrum, or maybe the children of those who are on the autism spectrum. And we would potentially want to test largely male infants since autism has a 4 to 5 to 1 ratio of males to females, and this does not match up with our sample. Our initial sample for study 1 was 40, we had 48 infants, 30 of those were female. Why did we have so many female infants? Well, it happens to be within the first day or two that the circumcision takes place, and this does not result in happy sleeping male babies. They are not, if you think it's a painless procedure, then this would suggest that maybe it's not, being that they were not sleeping for as long periods of time and were generally more fussy. So we might have to test it more on 1-month-old infants than newborns. So, of course, I'd like to thank my postdoctoral advisor, Dr. Pfeiffer, the nurses and staff of the Well Baby Nursery at Columbia to allow us access to this, the undergraduate assistants that helped the collaboration of Study 3, and then, of course, I want to thank the parents who allowed us access to their newborns. They were wonderful, and they also usually really enjoyed coming in and watching through an observation window as their child looked like he was being wired up to go to outer space. So thank you very much.
We have time for a few questions.
Yes?
A very difficult and complicated, very interesting study.
Uh-huh.
How do you pick up these children?
How do I pick up the signal?
Yeah.
Well, as saline gets into the sponge of the electrode and conducts the electricity from the scalp into the electrode, which goes to an amplifier that amplifies it to a large extent because it's just a few millivolts.
Are they all volunteers?
Yes, these are all volunteers. We would find out from the staff of the newborn nursery, what infants had been born the night before, were healthy, no evidence of, not preemies, no evidence of drug or alcohol exposure, and that the mothers were not so drugged that they couldn't give consent if they'd had to undergo anesthesia. And if they were, then we would send someone in to explain the study, give them an informed consent, and if they were willing to let us do this. And so we were doing it in the newborn nursery. We weren't taking them out of the nursery, and they could come observe. So many of them were interested. So, any other questions? Yeah? Yeah.
The question is, why so early you started observing this?
Oh, why would I start looking?
So
Well,
early.
so early in infancy?
Yeah, because the brain is still developing.
Yes, the brain is still developing, but there's some evidence that autism is genetic. If your infant, if your sibling is autistic, you're more likely to be autistic. If your parent is autistic, you're more likely to be autistic. And they're actually isolating some of the genes that seem to be playing a role in this. So it isn't that we think autism is completely nurture. We think it is a large extent nature. So there's no reason why we couldn't, if it's an atypically developing system, find some sign of the structure and functioning already not being completely in place or developing normally. So that's why, the earlier the better. Mm-hmm.
I have one.
Yeah?
Actually, I have a couple of questions, but I'll just ask one of them. When you did your female tone with
Yes.
with the
Yes.
newborns and everything, did you try, or did you think, or do you think there would be a difference if instead of using a just generic female tone, if you used the mother tone from the actual child, as you said,
Mm-hmm.
that they hear that
In utero.
in utero?
Yes, that is definitely one of the studies we'd like to follow up on. But it's a little challenging because we have to have the decibel level the same.
Sure.
We had them simply saying, "Hi, baby," in 900 milliseconds, but not compressed. We had to get a number of tries so that it isn't artificially compressed speech or slowed down artificially.
Sure.
It was a little tricky getting that normal speech rise and fall within the 900 milliseconds. I don't know. It would take some doing to get that from the mother and for us to do the auditory adjustments of the stimulus. But it's not impossible. We could get that done once if we get a procedure down for doing it, and you would expect that you would see it even more so, this conditioning response to their mother's own voice versus just a generic female's voice.
Okay.
Very good questions.
Anything else?
Thank you.
Thank you, Dr. Byrd.
Oh, thank you.